So hello, I'm Heather Hadjistavropoulos, and I'm a professor of psychology here in the Department of Psychology at the University of Regina, and also the director of the online therapy unit. And today I'm going to be talking to you about the work that we've been doing in the online therapy unit, both providing online therapy and then doing research on this form of service delivery. Before I begin, I just want to start with acknowledgements so I don't forget this. There's a huge team of people that's really made all of this work possible today. So first and foremost, I want to thank the patients who have participated and received online therapy. And not only that, but for the feedback that they provide us that helps us improve our services. Also want to thank the clinical team, so intake staff and therapists, our research team, other faculty members, graduate students, research associates and assistants, our community partners, so Saskatchewan Health, and the community mental health clinics spread throughout Saskatchewan, and then some groups from Australia at Macquarie University and Swinburne University who've been very generous in supporting the work that we've been doing. And I'll be telling you a little bit more about how we work with them as I go along today. Also really want to acknowledge our funders. So we started in this area in 2010 with funding from the Canadian Institutes of Health Research and Saskatchewan Health Research Foundation, and then we got a second round of funding that also involved some funding from Innovative Medicines Health Research Foundation, and then over the past several years we've also had some funding from the government of Saskatchewan. So really so many people to acknowledge up front who can take credit for some of the great work that I want to tell you about today. So just a couple of precursor statements that I'd like to share with you. So when I'm speaking, sometimes it makes it sound really easy, but there have been bumps in the road, and I'll share some of those bumps. And occasionally we've even hit a few potholes, especially when it comes to websites and things like that. But overall, I feel really optimistic about the work that we're doing in providing online therapy and feeling that this is really making a difference in improving patient access to mental health care in Saskatchewan. And I hope that's the message that you'll take home today. So in terms of my plan, I'm going to start by describing the online therapy unit and the background and how it's set up, a little bit of the history, share with you our patient utilization and outcomes, spend a little bit of time on patient-therapist communication, because that's quite interesting to most people, describe some of the therapist experiences, and then end with some future directions. I hope if you are a therapist or researcher who's interested in working with us, that this message or this presentation will be informative. Or if you're somebody from outside of the province who's interested in this area and working in the field as well, that the presentation will be beneficial to your experiences moving forward. So the beginning. You'll notice when I speak today that I have a lot of prairie scenes because I am a prairie girl. So the unit began, as I said before, with funding from CIHR, and they had a Partnership for Health System Improvement grant that they put out in 2009, and that allowed us to basically develop this online therapy unit. And the purpose of the unit was to try and improve patient access, specifically for the treatment of depression and anxiety. So I'm sure everybody who's watching this knows that depression and anxiety are highly prevalent conditions and also very disabling. Unfortunately, they're also most often undertreated. There's various reasons for that. One of the most common reasons is that when people have depression and anxiety, there's actually a preference to self-manage. And so that keeps people away from treatment. There's often stigma associated with seeking care, costs associated with care, mobility challenges, time constraints. Sometimes being in a rural or remote location can limit access. And then of course the nature of depression and anxiety can interfere with getting the treatment that people need. And so our group became interested in the idea of using internet-delivered therapy to improve the treatment of depression and anxiety, or patient access to treatment, because it's convenient and flexible for those who are limited by location, time, or mobility. And it really is a great choice for people who prefer to independently manage problems or are concerned about privacy. So there's lots of different ways of delivering internet therapy, so it can differ in terms of theoretical orientation, the amount of structure, the amount of support. And what we were really interested in was internet-delivered cognitive behavioral therapy. So in this form of therapy, the client goes online and they're reviewing educational materials on a weekly basis that are very similar to the materials that they would receive in face-to-face care. And then in addition to that, they have a therapist that's checking in on them once a week to provide support. And that check-in is typically by secure messaging, asynchronous messaging rather than synchronous messaging, and telephone contact on occasion. When we started out, it took a while to figure out how to deliver that care, and it probably took about an hour, very similar to face-to-face care, but over time, with experience, we find that check-in, the therapist check-in, takes about 15 to 20 minutes. And for some clients, it actually takes less, and for some, it might take a little bit more. So we were interested in this because at the time when we started in 2010, there was actually quite a lot of literature showing that this approach in randomized control trials was highly efficacious. And especially for the treatment of depression and anxiety, they were seeing outcomes that were very similar to face-to-face cognitive behavior therapy. In addition to that, patients who were participating were reporting a very high level of satisfaction and the ability to develop a therapeutic relationship online. So this was of considerable appeal to us. So we set up our unit to have sort of three things that we wanted to do. So first and foremost, we wanted to provide a service and try and get access to individuals who have depression and anxiety. And secondly, we wanted to be available to graduate students and to therapists in the community to provide education on how to do this in a way that would be efficacious and consistent with the research literature, but also safe. And then we wanted to conduct research as well, because I am a researcher. And so with the idea with the research is that by collecting research as we were providing the service, that we could be continually improving what we were doing. Because it's still a new area, there's still a lot to learn. And so we set up sort of those three areas, and we've, I think, made a lot of progress over time. So since 2010, till the end of December 2016, we'd completed almost 2,400 telephone screenings. 72% of those clients, or 1,700, almost 1,700, were provided treatment, with about 66% being offered treatment by therapists who work at the University of Regina, and 34% being treated by community therapists who work in a partnering community mental health clinic. So we're pleased with that level of service, and I'm going to tell you a bit more about that. In terms of the education, we've provided over 30 workshops with 233 people attending, and 168 of those have gone on to provide ICBT. So it's about 72% that take the workshop and then decide that they want some experience. About 68% of those that we've trained are registered mental health professionals. Sometimes we train people and they don't go on to provide the therapy, but they wanted to be part of the training because they wanted to be able to understand it better in order to be able to refer. In terms of research, you probably won't be able to read the details of this, but it does give you an idea of all the different trials that we've conducted. This is our timeline from 2010 to 2016. On the top were our studies that looked at disorder-specific programs, and I'll tell you more about that. In the blue are the studies that have looked at our transdiagnostic wellness programs. In the orange are the studies that we've done that have looked at delivering ICBT to individuals who have depression and anxiety but a comorbid medical condition. And then the blue are the studies that we've done on implementation processes. So lots of research. We've looked at efficacy, predictors, reach, how to best provide education, and how to implement. And sort of looking at strengths and barriers to implementation. So I have lots to tell you today about what we found along this journey. We've had very good success in the research department, so we've now had over $2 million in funding and had 10 formally registered trials, published lots of research, done lots of presentations. We've had 26 students who've done research within the unit, and are increasingly doing more consultation with other researchers in Canada and other organizations who have an interest in taking this journey as well. So, how does this work? What happens is clients hear about us in different ways. So about 58% of our clients come to us from a provider referral. 14% from a family or friend who've heard about us, 15% because of some media story, and about 11% it's just an online search that leads them to us. When they come to us, they go to our website, and on the website they can learn about our service and then decide whether they want to participate. We have a video online, and we've actually learned through our experience that this video is actually pretty important. So it's a 5-minute video, and it explains what our therapy is all about and the efficacy. And so we've done a little bit of research that shows that when people look at that video, we actually see an increase in credibility scores and also a pretty big jump in perceived helpfulness of this service. And we know that expectations, of course, of treatment are important. So in face-to-face care and in ICBT, those expectations can often predict how people do. So once they watch the video and decide this is the right service for them, then they start by completing an online screening questionnaire. And that screening captures lots of different information. So it takes about 15 to 30 minutes. It covers kind of basic information, symptoms of depression and anxiety. We get some information on the social and environmental factors, self-care and functioning, alcohol and drug use, any history of severe mental health problems, medical history, as well as past and current treatment, and any concerns they have about ICBT. From that, we take that information and we follow up with a telephone screening call and figure out whether they're a good fit for us. So in most cases, our clients are from Saskatchewan. We do offer a few programs across the country, but most of our courses are specific to Saskatchewan residents. So an inclusion criteria, everybody needs to be 18 years of age or older. They need to be reporting some symptoms of depression and anxiety, but we don't require a diagnosis. They have to have access to a computer and feel comfortable using a computer. They have to be willing to provide a healthcare professional as an emergency contact. They can't be at high risk of suicide, but of course they can have suicidal thoughts because those are common and would exclude too many people. They can't be experiencing primary significant problems with alcohol or drugs, or suffering from psychosis or mania. So assuming they meet these inclusion criteria and they're interested, then we set them up with a therapist. So this just gives you an idea of what we did in 2016. So there were 867 people who started on the online screening. We were able to follow up with over 700 with a telephone call, and of those, 600 were accepted for treatment. So there's a percentage of people that we do screen out, and the most common reason would be that they are too severe. And in that case, then we play an important role in trying to refer people to another service. Sometimes people are appropriate for the service, but they don't start, so they decide that this isn't the right time for them, and so maybe they'll call back at a later time, or that this isn't the right service. And in other times, they have started in-person services, and in that case we don't want to duplicate services, so they're excluded for that reason. But overall, we're at about 16% exclusion. I have to say that when we started, that exclusion level was much higher. So we started off very conservative, and over time we've learned that we can actually work with lots more people than we had previously thought. We've done a little bit of evaluation of the screening process, and just briefly wanted to say that people really like that process. They find it super convenient, and they've even said like they wish that all services started with this type of screening beforehand. the information that we collect at screening is not only for the screening, but it's then transferred on to the therapist who uses that to understand the patient background. In terms of therapists, we match clients either with a therapist in our unit or with one of our therapists who work in the community mental health clinics in Saskatchewan, and we're currently working with 9 different clinics. And we started small at 4, and we've just sort of gradually increased over time. And in terms of those community clinics, we basically have 1 or 2 therapists from a clinic starting each week, and they're kind of on a rotation. So the first week we would have somebody from Regina, the second week somebody from Prince Albert, and the third from Five Hills. And in the end, it ends up being a bit of a random assignment in terms of whether they get treated by somebody in our clinic or somebody in the community, or occasionally patient preference. So sometimes there's clients from a very small health region, and they have a preference for being seen by somebody in our clinic versus somebody in their health region. So they get assigned to a therapist, and then both the therapist and the client are given a username and password, and they log into the U of R web server, and that's where they access our treatment materials. And that's also where all the emails are exchanged. So there's no information that's going over the internet, and everything that's on the site is encrypted. And then we also have tight access control to that server and to the backing up and retaining that information that basically serves as the health record as well. Not sure how you'll be able to see this, but when they get online, clients basically see a page like this, and each week there's this kind of small folder, and they open up that folder and it tells them what they'll be doing that week, and the materials that they'll be reviewing are available that week, and those folders open up gradually over time. In addition to sort of the weekly materials that they access, there's some extra resources that are available to clients as well. And I'll explain more about those materials shortly. So, what have we found? First, we found this great picture. So, in terms of utilization and outcomes, we started off by offering a disorder-specific ICBT. And we were working with a group at Swinburne University. So they had developed materials and very generously allowed us to license those materials and use them in our studies. So we started with 222 clients, and we did screening, and then we assigned them to the program that worked or fit for them. So either generalized anxiety, panic, or depression. And each of those programs were 12 modules long, so they were supposed to have 12 weeks, and then in addition to that, they were to have contact with their therapist approximately 20 minutes. And when we set this up, we didn't say you have to do 1 per week. We let clients take the amount of time that they needed, and said that we would follow up with them until they finished those programs, because we wanted to see what this would look like. So what we found from this is that we actually had really large effects. So when we looked at measures of depression, anxiety, panic, people started off in a very clinical range. By mid-treatment, had reduced by half, and by the end, were in the area that you would see in the normal population. So large effects. So we were getting really good outcomes. What we were also finding, though, is that only about 50% of our clients were completing all of those 12 modules. And people would sort of drop off at various points. It was pretty equal from module 1 to 11. On average, people were completing 8 modules. They would log on about 40 times over the time period. They were taking about 19 weeks to complete, and actually people who fully completed were actually taking more like 23 weeks, so 2 weeks per module. And in terms of therapist time, it was about 19 messages from their therapist, or 19 weekly messages, and there were 2 phone calls during that period of time. So we did find really high patient satisfaction and really good outcomes, but unfortunately, we weren't super pleased with only getting 50% of people to complete. And so when we talked to patients and to therapists about this, what we were really learning is that we were offering a lot of modules that some clients just didn't feel were necessary. And we were also finding that clients would complete a program, so they would do the one for depression, and then they'd say, I want to do that one now for GAD, or I want to do the one for panic. And so we were seeing a lot of comorbidity. About 50% of people were saying they had comorbid condition. So with these results, although we were very encouraged by that, certainly happy to have helped 50% of people, we decided with our next grant that we would look into a transdiagnostic ICBT course. So with transdiagnostic ICBT, basically you're presenting a course that's appropriate for people whether they have depression or anxiety and different forms of anxiety. So you're teaching kind of core skills that apply across both those conditions. For this grant, we partnered with a group at Macquarie University, namely Nick Tiedoff and Blake Deere, and we were able to license their materials. The way it works is on the first lesson, clients learn about depression and anxiety and the cognitive behavioral model. In the second lesson, they learn about identifying and challenging thoughts, and they're given examples for both anxiety and depression. In the third module, it's focused on managing physical symptoms. The fourth is on graded exposure or graded activity in the case of depression. And the fifth is on relapse prevention. And those are released gradually over time. And for this course, we actually set some very specific timelines. So people were given either 1 or 2 weeks to work on each of those core modules, so that treatment lasted 8 weeks. They can actually access those materials for a longer period of time, but we tell them that you can have support from a therapist for those 8 weeks. In terms of how the materials look, just to give you a sense of that, they have PowerPoint slides. So with each lesson, there's text, primarily text, but it's supplemented with images that help the information be easy to understand. Lots of bolding and caps so that information stands out. So they basically look at a PowerPoint slide. In addition to that, they have downloadable guides, and these are guides that allow them to keep and retain information long term, so they can download it onto their computer, print it off if they like. And in those guides, there's also homework assignments that supplement the information that they've been learning. They also have stories, so they learn about other clients who've experienced depression and anxiety, and what it's been like for them and how they've used those materials. In addition to that, there's also these additional resources that clients can access. So instead of making everybody do all of the materials, it offers these 4 or 5 core programs or 5 core lessons, and then these additional resources, but only if they're necessary. So if you have sleep concerns, there's a resource for that and some suggestions on how to address that. Or if you're worried about problem solving, then there would be that, or assertiveness, etc. So in this case, the materials, again, are supplemented with therapist support, 15 to 20 minutes, and again, we limited it to 8 weeks. So this actually turns out to be pretty important and pretty helpful, because it does encourage people to get going because they want that support and want to review the materials while they have that support. In terms of that therapist assistance, with this program we've actually been more specific as well about what we want clients to be learning from their therapists and what we want therapists to be doing in those emails. So we encourage therapists to engage the client and ask for feedback, to provide the client with feedback on symptom progress that they're seeing in the questionnaires, of course to express concern and empathy, to provide extra psychoeducation or clarify things that clients might not understand from the materials that are online, to try and facilitate understanding of the client's emotions, thoughts, and behaviors and how they're linked and how to use the different strategies, to address homework and staying on track, and to assess and manage risk as it presents itself. That's kind of what they're doing, but in terms of all of those areas and how they do it, just like in face-to-face therapy, we talk about the importance of being warm and genuine, being personalizing the information to the clients. We also, though, talk about the importance of being brief, clear, and organized in the messages. So a really long message from a therapist might seem great, but it's overwhelming because they're already getting a lot of information. So we really encourage therapists to work on making those messages brief. So for this transdiagnostic course, we've had almost 1,700 clients complete this course, be screened for the course, accepting 1,200 clients, with 60% being treated by our unit and 40% in the health region. We've noticed a steady increase since we've been offering this course. We've had more and more clients enrolling. So in 2016, we treated 600 clients, but in 2017, we're actually expecting to treat 750 clients, with 450 by our health region, or our online therapy unit. So that's 3 registered therapists who are employed in our unit, as well as about 4 graduate students who work in the unit on a part-time basis. And then 300 clients being treated by 30 community therapists who are spread throughout the province. In terms of who's participating, the profile of our client doesn't look a lot different than a face-to-face clinic. So the average client is about 38 years of age, 73% are female, about 49% of our clients are coming from small cities or towns, 64% are married, 63% are employed full-time, 50% have a university education, 92% are Caucasian, 4% identify as being First Nations or Métis, 59% are on psychotropic medication, and 49% have some kind of current but infrequent mental health care, most often a psychiatrist or a social worker. It's just a heat map that shows where people are coming from. So we do see concentration in the cities, but about 50% coming from these smaller spread throughout the city. And of course, in the northern part of the province, it is sparsely populated, so we don't expect too many spots up there. About 26% of our clients tell us that this is the first time they felt comfortable accessing care, and we think that's actually a pretty important finding, because it's meaning that we're getting care to people who maybe wouldn't otherwise be getting care. 30% say they've used it before, but they still need help, and 44% are using it as a supplement to care. And 13% tell us that they're using it because they're waiting and they're on a long waiting list for care. There's an impression that when you offer ICBT that you're dealing with mild to moderate cases, but in fact 48% of our clients would fall in the severe category on the PHQ-9 or GAD-7. In terms of website use, we have high levels of participation. So in this 8-week course, they're online about 22 times. They send on average 5 messages to the patient. Of course, that's variability there. And therapists send about 9 messages to the client. There's usually in this program only about 1 phone call. And really importantly, we're seeing that 84% of people will complete the first 4 modules, and 78% will complete all lessons. And we go with that for the first 4 are kind of most important. There are certain people who will stop and say they don't want to do the relapse prevention, they don't feel like they need it. But on average, 84% of people will do all 4 of those lessons. We're getting very high satisfaction rates, so they'll say 95% of people will say that they felt it was worth their time and that they would refer a friend to it. In terms of patterns of use, we do see that about 72% of our clients complete all the modules and they communicate with their therapist in the way we expect. We then see some other patterns of use. So of course we have this 10%, they don't complete any modules and they don't email. There's another about 8% that they email, but they don't want to complete the materials. And then there's other people who want to do the materials, but they don't want to email. So we do see a little bit of variability, and patients, even though we're asking them to do both of those things, that sometimes they decide that they'll do something different. So with this program, so in addition to getting high completion rates, we're seeing really large effects over time. And so they're starting off in a clinical range on the PHQ-9 and GAD-7, and at the end of treatment are in a non-clinical range. We're not finding differences between our community therapists and our online therapy unit therapists. So about similar completion rates, similar effect sizes, similar levels of treatment satisfaction. We're really happy about that because in the online therapy unit, it's quite cohesive. There's lots of support for how you're providing the treatment. When people get out to the community, we're just want to make sure that they're still delivering the service in the way that we expect. So we do provide some support and supervision, consultation to them, but really they're doing the training and then able to deliver the service and get good outcomes. This slide basically is just talking about the extent of improvement that we see. So on average, we're about 50% of improvement in symptoms from pre to post, and we see very little deterioration. So that's when clients actually go the opposite direction. So at 1% for depression and 0% for anxiety. The patient feedback from clients is very similar. So if you look at the qualitative comments, it's very much in line with those quantitative findings, so showing high satisfaction and good outcomes. We just recently completed a study that sort of really got into the feedback from clients to figure out what do they like most about this course. And what was interesting was how much they enjoyed the stories that are provided in this course. They also really like the downloadable guide, so they like viewing information, but they want to be able to retain it. And then they really relate to the cognitive behavioral materials and those cognitive behavioral skills. They do give us some ideas for how we could improve things, so they actually suggest that we could even expand our stories more, providing more examples. For some clients, they want a longer timeline than 8 weeks. And some clients want more flexibility in terms of how they talk with therapists. So for a lot of clients, this works to be emailing and phoning, and others would like more contact, even having blended care, so some face-to-face care. We've examined predictors of response to treatment and completion rate. So interestingly, we find that the older a client is, and if they're unemployed, the more likely they are to complete. People who start our program who are younger in age, unemployed, have lower education or more psychiatric visits tend to start off more severe. What's really important, though, is that we find that people who start off more severe actually make bigger gains, of course, because if you start off higher, you have more room for improvement. So we are seeing that a high initial score will predict more improvement over time. So in terms of that patient-therapist communication, we have looked at therapist statements and emails and tried to understand a bit more about what therapists are doing. So what does this therapist communication look like compared to face-to-face therapy? And so in this study, we sort of looked at the themes of the statements that are written or the behaviors. And we compared that to another study that's been done also of ICBT and therapist behaviors, and found a lot of overlap in what we're doing and what another group is doing in terms of how they provide therapy. There's some unique things that we're doing as well, though. So we seem to give more administrative kind of statements about when to log on, and we ask more questions to try and probe and facilitate understanding, and we give more questionnaire feedback and symptom progress than other groups are doing. In terms of sort of how this works in an email, about 21% of the statements are about the alliance and trying to bolster alliance. 15% are sort of administrative statements. 14% are kind of task prompting, encouraging people to keep going and to work on the modules and to try the tasks. 14% of the statements are task reinforcement, like great job, I think this is really making sense for you. Psychoeducation is actually a very small percentage, so it's only about 10%. And sometimes people are surprised to see that, but it's really that the treatment materials do the psychoeducation, and the therapist is there just to add in and supplement that, rather than have that be the core thing that they're doing in the emails. and then about 9% are questions. You'll see there's actually very little self-disclosure, deadline flexibility in our program. In terms of comparability of those two programs, we do more alliance bolstering, task reinforcement, and psychoeducation than this group in Sweden. And they do more task prompting and self-efficacy shaping. And both of us are infrequent in terms of self-disclosure and deadline flexibility. So it's kind of interesting to compare, to see the similarities, but also differences in how ICBT is developed. We've taken that information and recently created an ICBT therapist rating scale that we now are doing research on and are using in supervision, so that when students or new therapists are learning ICBT, we use this framework to provide feedback on the emails and give them a bit more structure in terms of what they should be looking for. I won't go into all the details, but we have 9 different dimensions that overlap with those dimensions that I was just talking about. In terms of that research, when we've looked at, we took 404 emails and rated them on the 9 dimensions, and really found that the quality of the emails that were being sent was very good. So 69% of the ratings suggested no changes were necessary, that they were viewed as being appropriate and matching what the client had said. There was 10% of ratings where it was suggested like maybe they could have been improved, and in 21% of the cases the behavior wasn't present. We're not quite sure if it should have been present, so it's something actually that we're looking at. One of the things that was really interesting about this is actually the quality ratings go up the more the client rates, and that's very similar to face-to-face therapy. Of course, the quality of therapy looks better the more the client participates, and that's the same for ICBT. Just going to quickly go through this, but the main point here is that a big thing that we want to work with therapists on is that working in the emails to help do a little bit more facilitating understanding for the clients, helping them identify the emotions, thoughts, and behaviors and linkages that are happening, and then also working a little bit more on encouraging clients. So we've kind of identified 2 areas that we'll be moving forward in with therapist training in the future. We've done some work on patient statements and what are patients doing in these emails, and compared this to other research as well. And again, find very similar themes to what our patients do and what other patients do in other programs. But about 39% of their statements are about the alliance, forming an alliance with the therapist. 25% are about telling the therapist about patterns and problems that they're having. 11% are statements that they're saying they're noticing positive consequences. 11% is that statements about that they're trying alternative behaviors. We see very few statements about problems with treatment content or problems with technique. So it's quite interesting. Helps us understand more about this therapeutic process. In the unit, so that's kind of our core research, but there's been supplemental research that's led by students and some sort of extra little projects that we do on the side. So we've done studies that have looked at patient perceptions of ICBT in different groups. So we've looked at it. Patients, providers, students, chronic pain patients, health anxiety patients, and really the takeaway is that people do have positive perceptions about ICBT. There's always some concerns that we know we need to address, but perceptions are good. We've also done population extensions, so we've looked at the efficacy in older adults, women with postpartum depression, fibromyalgia, well-being after cancer, and we have a student now who's working in the area of cardiac rehab as well. And again, consistency in terms of what we're seeing. We're getting good participation rates, good satisfaction, and good outcomes in these populations. We recently have been working on offering a chronic pain program and are quite excited by the changes that we're observing. So pain stays the same like you would expect with chronic pain, but we're seeing reductions in disability, improvements in depression, anxiety, and avoidance. So it's a program that we feel quite optimistic about in terms of rolling out. And we know, again, with chronic pain, it's a prevalent condition that is often undertreated. want to tell you a little bit about implementation experiences in these community mental health clinics. So we did a survey of both providers and managers after 2 years of experience of delivering this transdiagnostic ICBT program. And we asked them at the end of that what their views of ICBT were, and we're really encouraged about the very high ratings that they gave to ICBT. So they said things like residents should have access to ICBT, community clinics should offer ICBT, that they felt that it's worth their time to be involved in ICBT. They also felt like they should actually be doing more of it. So of course there's a few therapists who felt they shouldn't, or they should do it the same, but the majority of people felt like they should do many more or somewhat greater. The therapist feedback is generally that there's some surprise when they first start in this area about the bond they can form with clients, as well as about the degree of efficacy. They also, though, talk about that it is challenging with some clients, especially those who are less communicative or less motivated, and that's just like in face-to-face treatment, that is challenging. They talked about sort of things that facilitate the implementation process and the extent to which ICBT is implemented. So the intervention itself seems to be a major strength that facilitates implementation. The quality, the research evidence, really liking this transdiagnostic program. They also talked about the really important role of the online therapy unit in implementation. So stating things like without that unit, they wouldn't be offering ICBT. And then they also talked about the really important role of strong leadership in the managers within these clinics, really wanting to be able to offer this service, feeling that it's very much compatible with the need to manage waiting lists and to offer step care. Barriers do exist. So in the community settings, a big issue is that there is definitely greater priority being given to in-person services. So it limits the amount of time they can allocate to ICBT. And they also noted they hadn't set really specific goals for ICBT. In terms of the intervention, they said, yeah, the majority of time it works great, but it needs to have greater adaptability for people that they're having challenges with so that they could offer more support, a longer treatment. And also it would be great if we could treat even more conditions other than depression and anxiety. And then they also talked about the importance of engaging all stakeholders, even doing more work in that area. So education of family physicians, of psychiatrists, of other providers in the unit, of patients, and all that work as being important for implementation. So let me conclude just with a few of our future directions. So first of all, we are working with the community mental health clinics on goal setting. And so that has actually resulted in a 25% increase in the number of clients they'll treat in 2017 compared to 2016. And we're really, really pleased with that commitment to ICBT. In terms of engagement, we recently developed a very fancy infographic that gives people a snapshot of the online therapy unit and our outcomes, and we've had a good response to that. The website always needs improvement, and we are working on that. We've applied for funding that would allow us to do some more work on personalized ICBT. So in the literature, ICBT does tend to be very structured and standardized, and really wanting to follow up on the feedback that we received both from clients and from therapists, that it would be very helpful to identify clients up front who might need a more personalized approach to ICBT, so more support and a longer duration of treatment. So we'll hear in May about the outcome of that funding. And we do hope in the future to offer some additional programs. So lots of people have different ideas about what we should be doing. So definitely alcohol and drugs comes up a lot for people who have mild to moderate problems. Eating disorders comes up. And definitely PTSD and OCD. So yeah, lots of conditions, and the desire for us to work with youth as well. So stay tuned. So my take-home message. I want to come back to this slide, and that's that I hope from this presentation you do feel that this is a promising area. We know that people who have depression and anxiety have gaps in care. And we know that ICBT is not the only solution, but I think it's part of the solution, and it starts to fill in those potholes and bumps in the road for them. And I think it's a very worthwhile area to be trying to improve patient access to mental health care. So take the leap, is what I would say. If you have questions, you can visit our website at www.onlinetherapyuser.ca. I have my phone number up there as well as our email. And yes, you can contact us, and we'd be happy to answer your questions. And we always get questions about either wanting to be a therapist with our unit or wanting to do a project with us, and we're always happy to entertain them. On that website, you can watch that video. You can actually take our screening if you really want to see it. All of the articles and publications that I've talked about are posted in a section called Study Results. You can get more details about those if that's of interest. So thank you very much.